The Center for Medicare and Medicaid Innovation just launched 7 new models in a single quarter. Team and Wiser went live on January 1st. Lead, Access, and ASM, the ambulatory specialty model, are coming in 26 and 27. They're testing mandatory most favored nation drug pricing with different models. They're paying for GLP-1 access with Balance, and they even have $100 million for lifestyle medicine interventions. This is the most aggressive use of CMMI authority we've ever seen, and it's happening while the administration is openly skeptical of whether any of this actually works. MSSP saved $2.4 billion last year against $1.2 trillion in Medicare spending. That's just 0.2%. So what's actually happening here? Is this value-based care 2.0, as we've heard before, or something else entirely? Today on the podcast, I'm talking with Duncan Reece, co-founder of Liza Health, former EVP at Iora Health, co-founder of Cohere Health. He's been building value-based care organizations for 2 decades. We're taking stock of where we actually are and what this unprecedented wave of new models actually means. Welcome, Duncan.
Thank you. Excited to be here.
My fellow health tech nerds, commentator, long time. It's so great to be talking with you on the policy stack. What else did I miss about your background and where you actually are today in value-based care?
I think I've sort of had a bit of a long meandering road, and I would say I got lucky landing in value-based care before it was called that. And I started my career actually at a company called Health Dialogue, and I was actually ahead of this podcast was reading back. I think we participated in a demo that was a precursor to CMMI even being established. Yep. And sure enough, Medicare Health Support, which was a failed demonstration of telephonic disease management, was something that I was involved in the early days. So I've been in more models than I even realized when you asked me to join this podcast. So
amazing. So from where you started, from where we started to where we are today, give me your assessment. A lot has happened. You've been part of this for a long time. I've been part of it for some of that time as well and seen the development. Where are we today?
I think big picture, some of the cynics could say the things we're talking about today are literally the same problems and challenges we were talking about 20 years ago, except it's more trillions of dollars of healthcare spend and worse outcomes and all those kinds of things. And I agree. And that said, I think the impetus is to continue to push for change. And what I appreciate about particularly folks in the administration working on new models is hey, we can't sit around and talk about all the things that aren't working. We need to try to find ideas that work. And that is a great vehicle to use the government and funding to do that. And so I think that's great. It doesn't mean they're all successful, as you sort of pointed out. And sometimes if you do too many, it can get confusing, particularly for the frontline providers and patients who are experiencing the care and payment that is embedded in these models. But I think we need to push towards a better future, irrespective of what's happened in the past.
Right. I mean, I don't know what the alternative is. We just kind of give up and say, correct, well, I guess we'll just ration care forever. I'm not sure what how that's an acceptable outcome for anybody.
One of the reasons I joined Iora early on in the journey, and Rashika Fernanda-Pule, who was the co-founder and CEO of Iora, and he's also the co-founder and CEO of Liza. I was just totally enamored with my first meeting with him. And one of the things he said is he was too pissed off with all these people just going to conferences and complaining about problems and no one was doing anything. And so he decided he wanted to do something. And I said, I want to work with that guy. And it took me a year and a half of harassing him before he gave me a job, and now I'm working with him again. Nice. I think bias to action is an important quality, and it's probably most important now with the advent of AI. I think it's the biggest technology opportunity we've ever seen in healthcare, and we better use it for good.
Yeah, absolutely. No, Rashika's definitely a change agent as well. Very much so. When I met him back in the IORA days as well, had a similar perspective as you. I think just let's go back to the numbers a little bit. What I heard recently from the administration was them really pointing out that big number around, how much Medicare costs and how much MSSP, which is the foundational in today's world, the foundational ACO model, sort of pseudo run by CMMI is kind of the best way we can put it. The Medicare Shared Savings Program. Well, it's in the name. It's about shared savings. Of course, over the years, they have evolved that program to include downside risk or dual-sided risk. But the fundamental core of the program was really around shared savings. So they said, hey, lots of ink has been spilled over this, over MSSP, but it's generated, around a little more than 2 billion in savings. And we spend, 1.2 trillion on Medicare. So we're spilling a lot of ink and doing a lot of stuff around these ACO models that aren't actually saving a lot of money for the government or for the taxpayers, so to speak. CMMI models also famously cost a lot of money to run. They cost money to design. They cost money to set up, they cost money to recruit participants, and they cost money to evaluate the way that the statute under CMMI requires. So they actually cost more than they return. But it's also meant to be an experiment and it's funded differently. How do you look at this? Is that kind of like a red herring, or just like we're looking at the wrong thing when we think about like how much does it cost to operate these experiments?
Yeah, I think like if you think about innovation in the context of any organization, it's very difficult to, and this is the core principle of Clayton Christensen and disruptive innovation, it's very difficult to get existing people working on existing problems to do new things in demonstrable ways. And you need to carve out teams who are different, who are funded, and who have the ability to move fast and break things. I would guess that the folks at CMMI and CMS probably think, hey, there's probably ways to build, develop, roll out, and measure more cheaply than has been done in the past. And so there's probably opportunities to save money in how these models are actually shipped. But you need that engine, just like a large hospital needs to invest in some ways to disrupt itself, or a large health insurer. So I think it's a red herring to say, hey, spending on innovation is bad. Otherwise, we're caught in the same trap that we talked about before, which is let's do more of the same and hope that maybe health reform comes and it works and saves us all. But, I think you and I both know that that's not a great way to live life.
Keep waiting. Keep waiting. Yeah, and so the other sort of big criticism that's out there in the world is like, we're just moving money around, right? You see a lot of optimization with some of the companies that were set up as MSSP matured, and the other new models that, next gen ACO, what became direct contracting ACO reach. These companies were set up to manage and optimize accountable care organizations. And in fact, we're just moving money around, good for the organizations who figured out how to play the benchmark game, so to speak, something we'll talk about a little later around some of the new models, but hasn't really fundamentally changed how care gets delivered. Do you feel like that's fair, not fair? Obviously, experience from IORA and others, right? Like there is some optimization happening, but there's also care transformation. There's a different way care is being delivered. Like, how do you respond to those criticisms that sort of like accountable care is just moving money around?
Yeah, I think so. I think there's a couple things. One, all payment models can be games.
Are moving money around.
Are moving around. So
right.
So like look at all the in fee for service, there's a lot of unnecessary billing, waste, abuse, fraud, all that kind of stuff, right? So that exists. In value-based payment, you have different flavors of money moving around. And it's funny, like I get a little bit frustrated when people criticize value-based care, because I think what they're criticizing is value-based payment, but they're talking about care.
Yeah.
I'm actually writing a new blog post on this, and it's, if you actually go back to the principles of what Michael Porter said value-based care was, it's actually low value care is bad. High value care is good. Like no one ever wants low value care. And it's just the way you pay for it might be a mechanism to accelerate high value care. And that is what I think when I think about VBC 1.0. It was, hey, can we use payment to accelerate higher value care? And I think what people found is, yes, there were some really shiny spots where you see many, sort of provider focused MSSP orgs in the ACO program did very well relative to hospital oriented ones. And you see the Ioras, the Oak Streets of the world who are top 1 and 2 out of 100 or more ACO REACH participants in terms of savings generated to the Medicare program in that model. And so you do see pockets where these things have worked, but you also see areas where it's not working, right? And so there's still low value care provided by organizations who are paid in value-based outcomes ways. And a lot of those organizations have figured out, wait, I can actually make money just by, really coding incredibly well and not actually changing how medicine is provided to patients. And that was another foundational quote that Rishika would pound the table at Iora, and he still pounds it today at Liza, is, hey, if actual care is not changing with actual patients, we're not changing anything. Payment doesn't change that by itself. So the way I think about VBC 2.0 is different kinds of payment is necessary, but not sufficient. And we have to work harder at developing better models. We have to work harder at making sure there's the right oversight, and we're evaluating quality and experience and important physician or clinician experience as well, and that these things are sustainable. And so, but I don't think there's ever any perfect silver bullet, which is why we need to keep experimenting.
Yeah, you make some really good points. I mean, just saying that one of these things is by itself bad doesn't capture the full picture. Some coding isn't sufficient. And if you're paid on something that is adjusted by coding, like risk adjustment, or you're paid from fee for service, then yeah, you should in fact determine that you have the right codes for whatever that procedure or that condition or whatever it was, right? Of course, that can easily be gamed and certainly has been. There's all kinds of examples from the Medicare Advantage world recently, and really strong signals from the administration that they are going through and auditing every possible thing. So in fact, coding should be accurate and correct. And that's kind of the end of the story. In terms of developing a payment model, CMMI thinks about, okay, what are the payment mechanisms? But they're payment and care delivery models. They also design a care delivery intervention alongside that. And right. For myself, when I was, helping with the development of Comprehensive Primary Care Plus at CMMI, there's obviously the payment side. I'm not really a payment model person, so I wasn't very much involved in that. Then there's like a care delivery redesign side. I'm also not a clinician or have a lot of care delivery experience, so I only had the experience that I came into the room with. The part that I was part of, which I think more and more CMMI is looking at, is how are we going to use health IT and data and these systems and interoperability to actually advance the goals of that payment model, the change they were trying to drive, and the care delivery and system redesign as well. And I think that's a critical third part that I think finally, as far as I can tell, is being looked at more carefully at CMMI and across CMS, but there's a lot of room to grow. What is your experience of the things that have been missing in these past models that have maybe made it harder to achieve the goals behind them of that, delivery redesign, that, high value care versus low value care?
And again, I'm not as deep on the policy side as you are. As an operator,
think about it as an operator. Tell me as an operator.
As an operator, it can sometimes feel like the models have been negotiated across lots and lots of people, and so it's sort of a political process.
Your assessment is. I can already tell you your assessment is correct. Keep going.
And what you feel is like, hey, it looks like we're solving for lots of people's needs, and what that oftentimes manifests into is, wait, these feel like really onerous compliance standards or the really onerous reporting standards. And like reporting is one of the things that if you haven't been in frontline operations, you don't understand, like, oh my gosh, what we're effectively asking is for these organizations to track this in highly manual ways, which is time and money and systems that could be better spent on improving patient and doctor relationships. And then I think that's some of it, the complexity and things like attribution. But these are all, by the way, real hard things to solve. So I think sometimes from the perspective of an operator, hey, there's probably an easier way to do this, but as an operator, I only have to negotiate with the people around me, which is a very small team. CMS and CMMI have to negotiate with huge sets of stakeholders, which is a really important process to get. You can't roll out a model and have societies push back and have different parts of the administration push back because they're not in line, or differences between Democrats and Republicans. So it's a hard job, and that's why I've chosen not to do it. I do think I agree with you though. Like if you look at, and there's still more details to come in the access model, but like they made some tweaks where they said, hey, guess what? For you do not have to have a certified EHR to participate in this model. That was at Iora. We started without a certified.
Big thing.
Yeah, we did not participate in Medicare for 4 years because of that requirement, and so that's a huge unlock. And just like some other thoughtful steps that have been put in place. And I agree with you. Now there are so many shoulders to stand on that didn't exist before. So data interoperability and the push that this administration and past administrations have made, like, hey, it is not okay for patients to not have access to their health data. Like that is a wonderful thing and necessary thing. And we need to continue to push on that. And now there's a whole lot more software that has been built that doesn't need to be custom built by an organization like Iora. We did. There are great companies that are moving fast, and more coming every single day when you think about the new AI unlock.
Yeah, you're making a really good point, which is that in the earlier generation of some of these more innovative primary care providers who were either working within Medicare Advantage or working within the ACO models like Iora, ChenMed, another example, I think all of those companies struggled, and this would have been, like roughly like 10 years ago or more, struggled with what you just said, which was the technology baseline requirements around certified health IT, certified EHRs. But certified EHRs, as someone who worked at one during meaningful use, were kind of like a tangled ball of yarn meeting very specific regulatory requirements that might not have resulted in an easy to use or flexible platform that could be better tailored for the needs of truly accountable value-based care, longitudinal care, right? They were not built for that particular need. So when you have a sort of a company that's built around, we're going to deliver, high value care in these models like Iora, you guys were sitting there going, okay, well, none of these tools really work for us as they are. And am I right in remembering that you guys built your own thing, or you forked your own, whatever you did something yourself that was not certified EHR?
No, we built it from scratch, and eventually it became certified, but that takes years. And It's also a set of capabilities and features and requirements that are the last thing you want to build relative to, again, I want my software engineers focused and designers focused on the things that move the needle with patients and with the clinicians who take care of patients. And so I think, and this is, I think, the big unlock with this exciting future is the cost of developing is going down significantly for companies in the technology space, which means the cost for accessing those technologies is coming down. And sort of paradoxically, a lot of people have pointed this out, is you see in healthcare some of the best adoption of AI of any industry, which is, as you know well, like the opposite of how things, you used to have to pay people literally to use new technology in healthcare. And I think that's in part because of how antiquated the system has worked, and there hasn't been much automation, and how big the problem is and how desperate people are for something different. So yeah, agree.
Can you talk a little bit, just for the audience to understand, what did you like? What did you need to build or have like a decade ago to run, these to run a primary care model with, driving towards high value care that you wouldn't otherwise have? Like, what did you actually need to have on the technology side to make it happen?
Well, I think actually, if you pull, like, what do you actually need versus what is required are
Yeah,
two
what do you
different.
need, not what's
Yeah,
required.
yeah. So like, famously, Iora's first practice was a very busy practice in Las Vegas, Nevada, where we were taking care of members of the Culinary Health Union. So folks who worked at casinos and who had very significant comorbid chronic diseases, and it was almost like a high needs Medicare population when you looked at it from a population health point of view. And we got started, and the day we were supposed to start was the day we turned on our EHR,
Oh gosh.
which at the time was actually called ISIS. We changed the name because of obvious reasons. It has since been called Chirp, and it didn't work. And the reality is that wasn't an issue, because guess what? We had doctors, nurses, health coaches, behavioralists, um, medical assistants who could take care of patients. And guess what? You write things down on paper, and people have been practicing medicine that way for a long time. And at the end of the day, it's almost a good thing that that's how we started, because you focus on what matters is, hey, how do we, literally with a line out the door, how do we help make sure we get the right people in the right order and treat their needs and build relationships with them? And how do we keep the technology in the background? Luckily, later that day, they got the thing working. But when you think about that from that context, the technology job to be done is, we want to accelerate relationship building between patients and doctors. And yes, we need to have e-prescribing, and we need to have, ability to document, and we need a task system, we need scheduling, we need labs, all that stuff. And we built all of those things. But the most important thing we built first was, that interface to build relationship. And frankly, the task system was the like priority number one. And luckily, all those things now you can buy out of the box, and you don't need to customize if you don't want. But if you want to, increasingly, you can customize those things.
Yeah, and you've sort of hinted at it already, but there is a potentially big unlock with the development of some of these AI-enabled tools, or things that have made building software easier. Like, how does that come into play where you are now, in the sense of what's easier now, what's different now in the technology landscape that will hopefully support this continued development, or whatever we're calling value-based care 2.0?
Yeah, little things like now, there's still the full-fledged EHRs of our forefathers, the Athenas of the world. But now you have these headless EHRs that are certified ONC, and allow incredible interoperability with the apps that you build or apps that others build. And you can create an experience for both your team and your patient that feels like your own experience, and not one that you're buying from Epic or Athena or someone else. And for some organizations, that's really important. For others, it's not. And so I think that's interesting. And then when you think about the health information network data, all of a sudden, and it's not perfect, but the idea that, we can somewhat reliably get access to all of the records of this patient with the push of a button, when many, particularly any practice focused on new patients, you look at their tasks, like the vast majority of tasks are focused on gathering medical records. And so some of those things are just like super easy, and in ways that were incredibly hard, which then again opens the opportunity to, hey, how do we focus not on that stuff, the commodity stuff, but how do we make it easier for doctors and other providers and other clinicians to take care of patients? And then how do we get the patient much, much, much more involved in their care? Yeah. And again, AI is going to be a huge unlock. And you just, in the past 2 weeks, whether it was Anthropic or OpenAI or other organizations, like, there's just so much happening here, which is really exciting.
Yeah, I mean, I think, it's always been a bit of a there's always been a bit of a, well, Medicare beneficiaries not going to be super engaged with their health records or with technology. Now in 2026, I think we can all accept that people have gotten old enough, who were younger before, who've been using technology now for a long time. That's very, very much changing. And there's more and more both regulatory policy and just like public sentiment unlock of people being engaged in their healthcare because they have to, because of the balance of cost and just the increasing pressures there. So it seems like those things are also starting to change over time. It'll be interesting to see sort of how that plays out. Let's actually go back to the new model landscape because we can talk more about access then. Looking, since you've been observing this place for so long, like there was like 7 models in one quarter, like one announcement after the other, every other day, something new coming out of CMMI. How do you even start making sense of this as somebody who's building in this space?
So I only focus on the ones that are relevant to me. So I
Good.
purposely do not.
Ignore the rest.
You shared some that I wasn't even aware of. So I think so. I mean, that is the advantage of an operator, is to just focus on things that matter to you. I do think that presents challenges for organizations that are that do lots of things. So big hospital system, you could argue every single one of those models is relevant to them. And, it's not clear to me, if I were an operator in a big hospital system, I've chosen not to do that for a reason. Like, how do you organize people and processes and change around a portfolio of things? I don't think you can. Unless you sort of have dedicated sort of skunk work projects that are like really protected, but even that's hard.
Yeah.
And so, I don't know so my concern with some of those organizations is we could look at this kind of like what happened with, and I don't know if it was even part of a specific model, but like readmissions into hospitals. And like, it was just really difficult for the hospitals to really focus on that in a way that was intentional without corrupting their business or losing focus. And we could see some of that, but again, I think that also reinforces like, hey, we've been in this era where you go to this big building for everything you need, but does that make sense? Or are we better off having really specialty focus areas for each of the different things that we need as patients, that have much more tailored experiences and technology and support? And so I think those organizations, those provider groups that are focused on primary care or on orthopedics or on whatever, will have an easier time adapting to these payment models than ones who have to look across all of them.
Yeah, I mean, I think in general, like large organizations or institutions have a really hard time with things that are very, cross department or cross sector, right? These are fairly existential things. It depends, of course, on your mix of
Right.
population. If you have a huge Medicare fee-for-service population, what other payers are doing. That's also a tricky part, right? Is that everyone's mix of population is going to differ and makes it really hard for there to be one answer. There's not one answer, right? It's going to be like a whole variety of things that matter to you.
Yeah, and it's like one service in that department, right? So like with some of these models in orthopedics, for example, it's just, hey, we're just low back pain, and so what about knees, hips, other joints? Like, it doesn't affect
matter.
that.
Right.
And so I think that's challenging. But I do think the bigger signal to pay attention to is, we're at this crisis point from an affordability perspective, and folks don't care. So we need to fix this, which I think should be the wake up call. Like, whatever organization you're in, how are you positioned to adapt to a future where you have much greater accountability to your customer, which is the patient, and those who are paying for care in addition to that person, which is often the government or an insurance company or an employer. And so change is sort of necessary. How you do it, there are easier places than harder places, obviously.
Yeah. So let's talk about a couple of them specifically. one of the models that we're pretty familiar with is ACO Reach, which of course began its life as direct contracting and became ACO Reach. And, the lead model is intended to be the successor. There's relatively little information right now available at where we are in January 2026, but we know that it's more or less a continuation of ACO Reach with some differences, trying to address some of the common concerns from model participants around REACH. Can you talk about direct contracting to REACH and sort of your experience and that of your peers trying to run and be successful with this model?
Yeah, and full disclosure, when I left, I left Iora at the end of 2018, and we were just sort of ramping up when that model of direct contracting was being built. So I can't take any credit for directly doing work against that model or expertise against it. But I think big picture, what a great sign, right? The government, which is holding itself accountable to taxpayers, is saying, hey, we think this was successful enough to continue, but we're going to improve it. And so those participants who thought, hey, attribution was a pain, or the baseline trending didn't work, or whatever all the issues were, that CMS and CMMI were listening to those concerns and is thinking about ways to address those. When I was at Health Dialogue in the Medicare Health Support Program, the program ran for 3 years. It looked like it was not saving money, and they shut it down instantly. So even though industry, the companies, including mine, that were a part of it, were saying, hey, you could improve it the way some of these insurance companies run these programs, and it could be successful, but there was no appetite to consider it because there was no CMMI framework to take risks like that. So I think it's a great thing. Obviously, TBD on the specifics of the model. The same thing with access, TBD. Like, what are the rates?
Yeah.
But we know that these folks have left, their roles in different aspects of companies and other areas of the economy to do meaningful work for the government. And I'm hopeful that we'll get to a good place with them.
Yeah, I mean, I think that the fundamental pieces which as an operator that matter around a lot of these ACO models are, of course, your attribution, which is who is in your model, who are you responsible for, and there's like all kinds of ways you can move that around, like mandatory, like voluntary. Somebody raises their hand and says they want to be in your model as a beneficiary. Implied. There's all kinds of different ways you can work with that and change that number. And then, of course, benchmarking, which is like, what is the baseline on which you're being measured for those shared savings or shared losses? And then how does that change over time? It's my understanding with LEAD that they are talking about removing the ratcheting of the benchmarking, which is where it gets harder and harder for you to be successful over time. Like I said, I'm not a payment model expert specifically. And so I don't know how that works with the requirements around the way that they set up and get models approved by the CMS actuary who says like, this is going to be something that might show savings or not. Who knows? I think the other thing around this that is interesting, as with access, is the 10-year timeframe. And that is something that we have seen with a lot of the new models in the Biden administration and also in the Trump administration, which I think is also, I think you might agree with this, also a good sign that we see some continuity of how we're going to set these things up. But what does it mean for you as an operator for these models to be like have this longer, like 10-year potential time frame versus like 3 or 4 years? What does that actually mean in practice for you?
I think as you have to evaluate it from a risk management perspective, is like, hey, is this going to be around for a while? And even the models that are 10 years, like you can't depend that it's going to be
still can be canceled, right? Like
correct.
we can still cancel it.
But the principle behind it is like, hey, there's real conviction. And so it should increase confidence. And importantly, as an operator, it's not just my confidence, but the confidence of all the frontline care delivery folks who are like, wait, are we doing this thing, or is this just going to go away? And being able to say, no, this is a 10-year program help set the tone to make people who are really nervous, by the way, doctors and nurses and others are, not pleased with the state of healthcare. So opportunities to improve confidence are great. But I think the other, and lots of people have made this point, you also can't bet your business on just one payment model, even if it is from the world's biggest
I
payer.
think so too.
So you have to, it has to work, and what you're doing has to work in other payment environments as well. I think the ratchet one's a great example. What you see CMS and CMMI doing, saying, "Hey, we'll go show that this can work," because that problem is one of the biggest reasons why you haven't seen more value-based payment in commercial insurance, right? There's this really penalizing ratchet that is particularly difficult in a lower acuity population. And that would be really exciting if there were indications that can work, because then you have Blue Cross Blue Shield of X say, okay, maybe now I feel more comfortable experimenting because someone's shown the way, which is very difficult to put your neck out and say, hey, let's go try something crazy in my local community.
It's an interesting point as well, because one of the things that we tried to do in Comprehensive Primary Care Plus back in the day was, of course, and many other models, get multi-payer participation. It was really a serious goal of prior administrations under CMMI is, can we get other payers, other plans to adopt a similar or very similar or a model that is as much as possible like our Medicare model in this case, so that we can get more participation and more alignment across the entire payer mix for a particular provider. I don't actually know where that stands right now with the current Trump administration. I probably should ask them. But I know that the Learning and Action Network, which was one of those multi-payer collaboration, I don't think it's active in the same ways as it was before. There's some questions about that. So I do think that's important, right? What you're pointing out is that if we could get more participation from commercial payers, it would make a difference as well.
My sense is they're very focused on it. I have limited touch points with the administration, but the ones I've had is like, that's explicit. But they're trying to do it maybe less with policy and more sort of, hey, everyone's going to do
get
this
on board.
thing.
Yeah.
Get on board. And you can argue with that approach. But hey, if enough people do it, then it becomes the standard. And, when you think about the end goal is like, how do we reduce complexity for patients and for physicians who are taking care of the patients? The fewer variations around payment reduces complexity, and also reduces the need to go hire consultants and technology providers to manage the complexity. So I do think it's really important. It does feel like the administration's focused on that.
Yeah. Let's talk about access, because it's a little bit different than some of the other models. It feels like a narrow approach, it is really specifically defined as outcome aligned payments for tech enabled chronic care in a couple of areas specifically. And the payment is actually going to be tied to meeting clinical targets. And really the focus being, I think, the other type of players, the original players in accountable care can be part of it. Providers can be part of it, but also some of these tech companies that do offer like tech-enabled clinical services or care, like the digital MSK providers like Sword or Hinge Health could also be part of it, because they do provide clinical care and they do bill Medicare and they bill other payers as well, but in a very specific setting with a very narrow purpose. So not a general purpose primary care participant, but could also be something quite a bit more narrow. What do you think about this as a approach that is like not a full accountable care model, but definitely getting at some of the same pieces of accountable care that we've all worked on in the past?
Yeah, I view this as like, hey, shame on us for not trying to be more aggressive and using technology to help Americans. And, you could look at the more recent announcement from, I forget the name of the organization that's doing interesting work in Utah of like, hey, can we get AIs to prescribe?
I think
Doctronic, right? And it's like, who knows if that's going to work? But like the point is, we should try. And And I think access to me is that is like, hey, we've got all these technologies, people are using them every day, consumers like to use them, at least a subset of the population. Well, let's see if they actually work. And I think, there's valid criticism that, there's might be a reason why none of them have contracted with the Medicare Advantage plans, because they won't work. But hey, CMS is saying we want to demonstrate that there's this opportunity, and we're going to be very transparent with what's working, what's not, and then people can vote with their feet, which is a great way to think about it. I think it's very to be determined on who actually can participate economically, when you think about the rates.
Right.
Because I think a lot of the technology enabled service companies are really people organizations, and they have some pretty significant unit costs to overcome. And I don't know how much CMS wants to support those costs versus, no, we want to push the envelope on more technology forward solutions, which sort of, draws itself to a natural set of participants that have no, variable cost in their operation. So I think we're going to see, obviously, on that. The only area where I think there's potential, you talked about early on, like, hey, confusion at the front line is, I think it's natural. Right now, the PCP, the primary care provider, is sort of the node of, hey, I'm the person that the patient comes to for everything. So all four of the issues that Access is trying to innovate around are presented at the PCP office. And so, hey, there's going to be a lot of complexity of patients being made aware of these different things and providers trying to assess, like, wait, how do I actually integrate with them? And I know I get paid $10 a month, but I don't know if it's worth it, for me to actually spend the time of that. And so I think the folks who are particularly adept at making it easy and have it make sense to integrate with primary care, I think will be particularly successful, and also have a much lower cost of acquisition to get patients. But some of those details are to be determined.
Yeah, heart health, diabetes, kidney care generally, behavioral health, musculoskeletal, are all things where there are like tech-enabled services and technology that's available for the commercial market. Musculoskeletal above everything for sure now, but not widely available to every Medicare beneficiary unless they want to somehow pay on their own. And I think the piece that's been missing from my perspective, obviously I have a bias here, having worked on health IT and data and AI for some time, is that connected data. It should be 0% effort for the primary care physician or their practice or a care manager to be able to incorporate those data and those outcomes from a third-party tech provider who's working with that beneficiary. But in reality, we all know that it is not trivial. It is a really big deal. And, paying the primary care practice, like $100 a year is not going to cover the expense and the time to really integrate and understand those data. And that's where I get worried about it falling apart, is not that the technology and the protocols and the apps out there won't work. Innovator itself has a virtual cardiac clinic, which has great outcomes, will definitely be part of this. I worry more about, can all of us and can those primary care, providers get those data and those inputs into their systems, into their care management protocols to understand this beneficiary, this person, this patient, is working with Story Health, is working with Sword, is working with, whatever. And I'm getting all their data and looks like they're well managed. So 2 thumbs up. Unfortunately, it's a little bit of a pipe dream still with all the systems.
Yeah, and I think it sort of warrants, like, oh, that's a problem to be solved. And historically that would have been a really frustrating thing. It's like, oh my gosh, now a new payment model. We're creating a whole new cadre of technology solutions that people have to go buy to manage the complexity. But I think when you actually think about what's the core job to be done, is like, hey, primary care physicians and patients need to be able to better manage holistically all of the information relevant to a patient, all of the services they're consuming or could consume in a way that's shared between them. That seems like a really interesting problem for companies, independent of whether access is happening or not. And maybe now there's a little bit better of a financial incentive for those companies to do it. So it may present a really interesting opportunity.
Yeah. So as somebody who has, built in this space and been doing this for a while, what's your advice or like warnings to like folks who are coming to this new because of the idea of access? Like, I'm a tech enabled services company. I'm a technology company who can do this. And this might be their first like foray into the accountable care world. Please give some advice to the people who are interested in access and who haven't been in this world before. Don't have that 10, 20 years of baggage like we might have from working in the different models for so many years.
Here, one bit of funny advice: don't promote that you are accepted into the program until CMS allows you to. So that's one piece
Fair
of
point.
advice.
Fair point.
I've seen that. I think more thoughtfully, don't bet the farm on it. And I think the reality is most boards and investors have learned the hard way that you can't bet the farm. I think get into the details of how it works, and be really thoughtful about all the components that you have to get right in order to make it work. I haven't done this myself, but I think a lot of my sense is that CMMI and CMS really appreciate lots of feedback and interaction. And so, plan to be active, because they are listening and they make improvements, as we're seeing with, what will likely come from LEAD and how that evolved from ACO REACH. And and it also the age old trap is don't let payment fool you around what the end goal is. Payment is a means to an end. It's what we're looking for is value-based care. If you're focused on that, that's the direction we need to go. And yes, align the incentives to get there. But if you start optimizing for payment and you're not addressing improving actual care, then that's where you're going to get into trouble.
Yeah, definitely. So I know that you're not a policy guy, but I do have a little bit of a rundown of the policy stack involved in all this stuff that we're doing. So I think fundamentally people need to understand that there are so many layers that go into making all of this work. And the first is just like fundamental statute around the Affordable Care Act and Section 1115, which is how CMI was actually created. So not really that long ago. And also, interestingly, funded with $10 billion for 10 years, which has already been renewed once. And that's kind of the underlying foundation. And then there's all of this sub-regulatory stuff with CMMI, as you noted, right? These like RFAs, the request for applications, all the policy documents they're sub-regulatory. They're like people at CMMI, like me at the time, like writing up our best guess of what we think the policy and the rules should be around every operational issue. And you mentioned, Duncan, that, giving feedback is important. That's one of the areas where giving feedback is really important because people who write those, policy, those, model specific rules and participation agreements are smart and educated, but they certainly don't know everything about running, an accountable care model. So that's an area like very much to give feedback on, even though it's published by the government. It's not a law. It's like a rule for how to run a particular thing. And then we still have these quality programs, MIPS and QPP, that are, I think, like dying a slow death. But they still exist, and they're like all kinds of baseline requirements, like you were mentioning, around, health IT usage and how you actually have to report certain like fundamental quality measures that can be waived in models, but are a huge amount of burden and things that you have to do differently for each model or each program. If you bring Medicaid in, there's a bunch of state laws and state policy. There's a bunch of health IT and HIE infrastructure around, previously TEFCA, but TBD, the CMS health tech ecosystem, which is very much aligned with access's goals, things like that. Then there's other stuff that gets waived a lot, like the fraud and abuse waivers. So I don't know if you have any stories from how that's played in, but anti-kickback and Stark and things like that that can be waived as part of models. And then I think the kicker for all of us is like this all sits on top of the fundamental Medicare like payment policy, right? Like the Medicare physician fee schedule, which rules the direction of like how CMS pays for any of this stuff. What did I miss? Anything stand out for you there that has like affected your work more or less?
I've missed some of those things. So I think the point is that there's an incredible amount of complexity. A lot of
Yeah.
that complexity is built into workflow and systems that exist today. And I can't tell you how many times I've talked to people like, oh, we actually never turned on this thing in Athena to actually be able to get this kind of payment. And so people don't understand it, which probably means like, hey, there's a renaissance opportunity for people with policy experience to help companies understand this stuff. Or, maybe ChatGPT will build a feature that's focused on that and put those folks as experts only. But I think there's a lot, and I think it's important to understand them. I also think it's, as much as I hate saying this, I was taught also by Rashika, read the actual regs. Don't just do
Yes,
things because
yes,
people
yes, yes.
say. And HIPAA is a great example of that, where people misconstrue what it's intended to and what it is doing. And so it is important that you pay attention to the details because they matter.
And please don't use ChatGPT to summarize everything, especially if you
Yeah.
are actually
Mm-hmm.
participating in one of these models. You have to read it yourself with your own eyes. It will not get everything right. One of the funniest things that ChatGPT gets wrong when it summarizes, all these things is it gets the hilarious acronyms that CMS has created wrong and like makes up new acronyms. It's the funniest thing. Somebody should study that, not me. Um,
Yeah.
to close out, Duncan, the CMMI strategy says that all the models need two-sided risk and they have to show real savings that are getting canceled. You have been operating this space for a long time. You know what it really takes to make one of these programs to be successful in practice. What would you tell CMMI, since they seem to be skeptical of the future while also putting out a bunch of new models? Like, what would you advise them about making this successful? What do you want them to know?
I think continue to look for ways to simplify. I agree. I think folks criticize, sort of when they criticize value-based payment, they're criticizing risk, they're criticizing two-sided and all that kind of thing. I think the reality is not a single, maybe only the patient, but not a single actual payer of healthcare has any interest of putting more money into the system, and we need to take it out. And so I understand why people, complain about the complexity of these models, but this notion of we need accountability is not going away. That has support on both sides of the aisle. But I think it's really important that we try to find ways to make it as simple as possible to administer, which isn't easy with complex financial calculations such as risk sharing and benchmark methodologies and those kinds of things. So I get it. It's hard to have your cake and eat it too, but as much as we can simplify, that will just make it that much easier for, again, the end goal, which is patients getting better care from their doctors.
Awesome. Well, where can people find your work and learn more about what you do if they're interested?
We're My company is pretty. We're not out talking too much about what we're doing because we haven't done that much yet. But more to come there at Liza. I do write from time to time on a Substack blog called The Treatment Plan, and I'm actually writing a post, as I said before, around the difference between value-based care and value-based payment. So that hopefully will be done pretty soon. And then I'm a somewhat active participant in some Slack channels like Health Tech Nerds that you said, and happy to engage with people in any of those places. So
Awesome. Thank you so much, Duncan. Great talking to you.
likewise, thanks, Lisa.